I'm Dr. James Dyck from the Mayo Clinic. I'm here with my father, Dr. Peter Dyck, also of the Mayo Clinic. And we're going to talk about a review article that Jennifer Tracy and I wrote about history, diagnosis, and management of CIDP, or chronic inflammatory demyelinating polyradicular neuropathy. Now, Dr. Peter Dyck is not an author on this paper. However, I think he's the most important person when it comes to CIDP that exists. And the reason for that is that he initially and originally described CIDP in 1975, and that was published in the Mayo Clinic Proceedings. Subsequent to that, he went on to show that prednisone was an effective treatment for CIDP, and then the plasma exchange was an effective treatment for CIDP, and then eventually that intravenous immunoglobulin was an effective treatment for CIDP. So really, he both described this disease, showed what its pathology was, and showed what effective treatments are for CIDP. So it's a real honor for me to have you along today to discuss this illness with us. How did you originally recognize CIDP?
So my career at Mayo began in 1959. I had done 4 years of post-medical school training in Canada before coming here. I fastened onto peripheral neuropathy early, but it was mainly studies in inherited neuropathy. But increasingly, I began to be referred patients with other kinds of neuropathy. And one of the groups of cases I saw were chronic neuropathies which had unique features. Typically, they involved all four limbs. They were severe. They had a very distinctive abnormality of nerve conduction. Their conduction velocities were low and they were dispersed. We began to biopsy these nerves and found that there was segmental demyelination and inflammation. So I began to think of them as a chronic variety of an inflammatory neuropathy. And so by 1975, I decided to pull these cases together. Now, cases like this had been described in the European literature from the latter half of the 19th century. And but it was never clear exactly what they had. And then Jim Austin from Portland, Oregon, had also described chronic neuropathies, but he also, although let me back up, he had one case that had responded to cortisone, I think 19 times. But then he reported cases like that along with inherited neuropathy, and so I thought we should separate out the group of patients that were like Guillain-Barré but weren't Guillain-Barré. They were different in having a different course, findings, neurophysiological features, and pathology. Also, we began to be able to do post-mortem studies on a few cases and found that they had combinations of demyelination and remyelination, inflammatory infiltrates, and it was a patchy involvement. Somewhere along the line, I also read the paper from Waxman and Adams, done a decade earlier, in which they described allergic neuritis. So the idea grew in my mind that there were this distinctive group of chronic inflammatory demyelinating cases that had a broad distribution affecting nerve roots to different parts of the peripheral nerve, and that maybe an appropriate designation would be chronic inflammatory demyelinating polyradicular neuropathy. Originally, I guess we didn't emphasize the demyelination, but it was clearly there. So in our report that you, I think, alluded to in 1975, think we had 53 cases.
53 cases that you'd followed for more than 7 years on average.
That's right. And some of them we'd done postmortems on, and we thought that they did respond to prednisone. So we thought it was worthwhile to set this group of cases apart and treat them.
So how did you decide that it wasn't just a length-dependent peripheral neuropathy, and where did you come up with this term of polyradicular neuropathy?
Well, in the nerve conduction studies, both the proximal segments and the distal segments of nerve showed low nerve conductions. They also showed dispersion, actually. And then, especially on post-mortem examination, we had actually Dr. Haru Okazaki, a neuropathologist, helped me with these studies, and we made a big point of trying to get long segments of nerve, including nerve roots. And we found the pathological changes in the nerve roots and in proximal nerves extending to them. For example, in the paper, we have a striking picture of a proximal nerve which has large fields of onion bulbs, evidence of D and remyelination, adjacent to a large mononuclear cell infiltrate.
That's taken from a proximal nerve?
From a proximal sciatic nerve. And then in another field, you see just the onion bulbs. So clearly, this was a disseminated process affecting, in a patchy manner, different regions of nerve roots, segmental nerves, the plexuses, and then the peripheral nerves.
You went on to treat a lot of these people, and you just didn't give them therapeutic trials, you actually did controlled clinical trials. Jerry Mendel, another prominent neuromuscular neurologist, told me years ago that he thought you changed modern neurology more than anyone else because you brought controlled trials to neurology. You did a plasma exchange study versus sham exchange in these people. Can you tell us about that study?
Yeah. That study was done with Dr. Al Pineda, who was in charge of our pheresis laboratory. And in discussing it with him over coffee, we decided we could do a really exciting study by really blinding the patient from the treatment. We probably didn't mask the examiners to the same degree as the patient. But for example, we actually set up the patient with the infusion line. We had the infusion infiltrating into the vein so that when the pheresis was done, the patient would see blood flowing through the tubes, going into his arm, coming back out. But the point was that in one case, we actually did plasma pheresis. The other one was a sham.
So you took the blood out and put it back in?
Right. And so, for example, we had a really sophisticated patient. As I recall, he was a geologist. And you see, I knew what I got because I could see the blood going in, and so I knew I was on the real exchange, not on the sham exchange. I later looked up, and he was on the sham exchange.
So you tricked him?
We did. So in the case of immunoglobulin, the results were really astounding, because the patients who received the immunoglobulin improved remarkably by a tool we had introduced called the NIS, or as people now call it, the NIS. But the NIS is simply an adding up of neurological impairments from examination of muscle weakness, reflexes, and sensation. And during the treatment with immunoglobulin, they improved dramatically. During the washout period, they began to worsen again. And so we had numeric values for that worsening and the improvement.
So the NIS stands for...
And you could subject it to statistical analysis.
The NIS stands for the Neuropathy Impairment Score?
Yes.
And that's the study in which you compared plasma exchange to intravenous immunoglobulin?
Yes, as an example.
Do you think plasma exchange or intravenous immune globulin works better for CIDP? Does one work better than the other?
Which are you comparing, IVIG versus what?
Plasma exchange?
Oh, plasma exchange. We thought they were equivalent, but clearly IVIG was, in some respects, much simpler. You didn't have the patient, this could be done in the home. You didn't need the big apparatus. They seem to be roughly equivalent, actually, in terms of efficacy. Clearly better, though, than prednisone.
In your view? A lot of the world
Well,
uses prednisone still.
They do, but I think the evidence is clearly shows that IVIG or plasma exchange are more efficacious.
A lot of people now think that IVIG works well, but it isn't the answer because you need ongoing treatment, potentially forever. What's your views on that? Is there much hope on the horizon?
That I don't know. It is clear that you need to tailor make the dosage and the frequency of the plasma exchange or the IVIG to the needs of the patient. In my view, that isn't done carefully enough by most people.
So how do you do that?
By periodically examining the patient, doing the endpoints assessments that you use as your indication of whether more treatment is needed, and the NIS is good for that purpose. Nerve conductions are good, quantitative sensation is good, and then you adjust the treatment frequency and dosage to the patient's needs.
So you titrate to what the patient needs.
Right.
Very good.
And you can really get down to small levels of treatment in some cases. For example, some children need only a small dosage given infrequently to maintain good neuromuscular function, whereas some patients with severe disease need large amounts of treatment frequently given.
Well, I think we could talk all day long here, but that's a little overview of CIDP. The article that we wrote is really a review article about what's happening in CIDP, but an awful lot of it emphasizes the career of Dr. Peter Dyck and the work of Dr. Peter Dyck. And I think it's exciting for me to write this review article in Mayo Clinic Proceedings when the very original paper describing CIDP was published in Mayo Clinic Proceedings. So I want to thank you very much.
Thank you.
Thank you.
We hope you found this presentation from the content of Mayo Clinic Proceedings valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you will find access information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.